typically a myeloma patient will have at least 30% myeloma cells in the bone marrow, but it can be as high as like 90%, where there's a very high level of myeloma in the bone marrow. And obviously this indicates the severity of the disease, the staging of the disease, and things like that. The characteristic feature of myeloma is that these plasma cells produce what we call lesions in the bone. Now, this is a picture of the forearm of a myeloma patient, and you see the bones there, which are kind of whitish, and the lesions are the dark spots. Now, this particular patient had a lot of myeloma lesions in the arm, which would be actually very unusual these days, in that we typically would pick up the myeloma, diagnose the myeloma much, much earlier, before all these lesions would have developed. But this has the advantage of allowing you to see what can happen if myeloma lesions are allowed to grow. You can see that there are lots of them, and this is why we call myeloma multiple myeloma. It's a disease where there are multiple lesions in the bone. A lesion is where the plasma cells, so these dark spots are areas where the myeloma has built up, and then they have triggered some damage to the bone around the plasma cells. And this is what is called a lesion. And normally we call it a focal lesion, where it's just in a one spot. Sometimes it can be more what we call diffuse, where there's a darkened area that will extend all the way down the bone. Now, along with that, we have blood tests, which are extremely important in the case of myeloma. And so there is something that is called the myeloma protein level. And this is measured on something which is called SPEP, S-P-E-P. So this is a blood test where protein electrophoresis is run. So serum protein electrophoresis, SPEP. And so on that, you can see over to the right, there's an extra protein which is in the form of a spike, and it's the big blue spike over on the right-hand side there where it says IgG. So strangely enough, on the left, you have a spike which is albumin, which is a normal protein, but the one over on the right is an abnormal protein, and that is indicating the myeloma. So the myeloma cells are in the bone marrow, and they produce this IgG, which goes into the bloodstream, because normally it goes throughout the body to fight infection. And so you probably heard this related to the current COVID crisis, where we're interested in antibodies which actually attack the COVID virus. And normally that's what's happening, but in this case, this is an abnormal IgG which enters the bloodstream, and we want to know the amount of it. And the key thing for you to know is that the amount of this IgG reflects the amount of the myeloma in the bone marrow. So we don't need to be constantly doing the bone marrow. That bone marrow test, which is essential to diagnose the myeloma at the beginning, we then monitor the myeloma by looking at the amount of that spike protein on the SPEP. And as it gets lower and lower, then you might need to use immunofixation because it's just a tiny amount left. In some patients, there are just light chains, and I'll talk about that in a minute, and that's called free light. And in those patients, the disease is monitored just by measuring the light chain levels using a free light test. Now, in addition to that, in myeloma patients, we monitor the level of the calcium. If there's a lot of bone damage, the blood calcium level can go up, and this can actually damage the kidney. So we track the kidney function, and we also track the liver function. If you have a light chain type of myeloma, this tends to come out in the urine, and so that we track that with urine testing, and the urine testing can also show us if there's any evidence of kidney damage. So these are things that are important: the calcium, the kidney, the liver, and the urine testing. So a few just bullet points. Myeloma, not generally hereditary. So people want to know, will anybody else in the family get myeloma? Chances are no. There are a few families where more than one person in the family has developed myeloma, but this is really quite rare. A small percentage of patients where that would happen. So in general, you don't need to be worried about that for your children or other family members, for example. There are different types of myeloma. The commonest is IgG, but there's also IgA and IgD, and also rarely IgE. There is an IgM type, but this is typically another disease which is more like a lymphoma that we call Waldenstrom's. Baseline staging is important just to see how much myeloma do you have at the beginning. As you can imagine, that's very important to track to see how you're responding to treatment. How much is there at the beginning? What stage is it at? Is it just a small amount like stage 1? Is it a little more stage 2? Or is there a lot of myeloma spread around, which would put you into a stage 3? And we have information on the website about those different details, obviously. Another thing is to look at what we call diagnostic criteria, just to make sure the diagnosis of the myeloma and kind of the staging of the myeloma. And so in the old days, we used abnormal testings in bone and kidney and anemia and hypercalcemia. So what we call the CRAB features, so the calcium level, the renal function, anemia, and bone lesions. And so traditionally, at the time of diagnosis, patients would have at least one and maybe several of these features where their blood calcium was high, very anemic, and things like that. However, here recently, we pick up the disease earlier, and so it may be just based on the percentage of plasma cells in the bone marrow, more than 60%, which I show at the bottom here, or just an abnormal free light ratio, or maybe just a small number of lesions, more than one of those focal lesions, and on an MRI, which is more sensitive than X-rays. And so there's a movement away from the CRAB criteria, which we used to see a lot of in the past, with patients having a lot of bone lesions, a lot of bone pain, kidney problems, and severe anemia, and more towards the earlier features, which make the disease much easier to manage without problems. So we do extra testing to tell us a little bit more about the myeloma, and some of you will be aware that when your bone marrow test was done, there was something called FISH chromosome testing done, and this is fluorescent hybridization, and this is where the normal chromosomes are colored, and then using a special microscope, you can look to see whether some of the chromosomes have combined together. So you'll see each chromosome has a different color, like a red and a green. So if you see a red spot and then a green spot, it means that those have come together, and that's what we call a translocation. And so, for example, an 11 and a 14 come together, those spots come together, we know that there's a translocation, and we've learned that these chromosome abnormalities have a particular meaning. In the case of 11-14, that actually means that patients tend to do unusually well with treatment. So this is something helpful to know. In other cases, if there's a loss of part of chromosome number 17, we know that there could be more difficulty in achieving a stable ongoing response or remission. We typically now will use things other than X-rays. We'll do maybe a whole body low dose CT, or we will use PET scanning and MRI. And with those, you can use different image techniques, so that with the PET scanning on the left, the lesions in the vertebra show up as yellow. On the MRI, the lesions show up as white, and then over on the right, where you can see lesions all around, the lesions actually are dark in that case, and they can be focal, which is F, or diffuse, which is D. So there's a diffuse involvement of the bone. So we tend to talk about lesions which are focal or diffuse, and we tend to focus on where are they. Obviously, when they're in the back and spine areas, that's where we worry about pain and collapse of our vertebra, which some of you may in fact have experienced. So we follow the myeloma by tracking the blood tests, the SPEP and the blood counts, and we also track the urine. Now, it's really quite cumbersome to track the urine, and so it's very, very helpful that if you have a light chain type of myeloma, we can track the free light chains in the blood. And so many of you are getting the free light test, where it can be either kappa or lambda, and it's good to know, are you a kappa or a lambda? Because obviously that's the one where it's elevated with the myeloma and would be coming down as you respond to treatment. Now, it's called free light chains because a normal IgG or IgA, the light chains are connected to the heavy chains. And so in active myeloma, the light chains break loose. And so that's an indication of active disease. And so when you have a lot of free light chains, that means the myeloma is active. And that's why it's very helpful to track the level of these free light chains. So the first thing that myeloma patients want to know is, okay, I'm going to start this treatment. How do we figure that the treatment is working? And so that's what we call response. And with the treatments that we have these days, with what we call a triple therapy, 3 drugs, like if you take Velcade, Revlimid, and Dex, which I'll talk about in a moment, the response occurs rather quickly, so that within the first 1 or 2 months, the myeloma protein level is going to be coming down. And so this is what we call response. So a partial response, which is what we technically call a response. So that's kind of a, when people talk about an overall response rate, it starts with a 50% reduction. So if the protein level starts off, let's say at 4 grams and then drops to 2 grams, that would be a 50% drop. And so that would be a partial response. Now, if it drops more than that, if it drops from 4 to 1, that would be a 75% reduction. That would be a very good partial response. And if it turns out that the protein goes completely away and there's a 0, then that would be a complete response. And then if in addition to that, the free light test, there's no active free lights floating around, and the bone marrow plasma cells, the myeloma cells drop below 5%, this is what's called a stringent complete remission. And so these are the different levels, but we're looking to achieve at least a partial response. And then if that's sustained, that's what we call a remission. And so if we move forward here, there can be a deeper level of response. And this you will start to hear about more and more, where when we're looking for a deep response, after 3 months, 6 months, or later on in the disease course, the doctor might say, things are looking really, really good here. You've had a complete remission. Let's see if the myeloma is really gone. We'll check if you've had a deep response, and we're going to check for minimal residual disease. Is there any myeloma left, which is what we call residual disease, and is it at a low level? Now, this is done with specialized testing, and so bone marrow samples are sent to the lab, and now we're looking also at blood samples where we can measure this, looking at myeloma cells in the blood, but mainly it's in the bone marrow, and you can look at different levels of sensitivity. What we're trying to achieve is at least 10 to the minus 5, and if it's really great, it's 10 to the minus 6, which means that we look at 1 million cells from the bone marrow and none of them are myeloma. So that's obviously fantastic, that you've had a really, really deep response. And so you'll hear a lot of discussion about that and how it could be good to try to get to that level, if possible. So remission, that is where the response is sustained, typically for at least 3 to 6 months, so with follow-up testing. So it's not just like the protein comes down and then it might go back up again. Remission is where the response is sustained. The length of the remission is what we call progression-free survival, or PFS. And you're going to see that a lot on different slides, PFS, and that is looking at the length of the remission. And so what that means is that's the length of the time in which the myeloma protein stays down. So if it's dropped down from 4 to 2 to 1 to 0, and it stays there, that is progression-free survival. But if it goes back up by at least 25%, that is what we call progressive disease or relapse. Now, as you could imagine, sometimes that can happen and nothing else has changed. We haven't noticed any lesions, you're feeling fine, no actual problems that you're aware of. And this is what we call biochemical relapse, where the doctor says, oh, unfortunately, the protein level has gone back up a little bit, and so maybe we're going to have to change your treatment. The other thing that we look at is overall survival, and that is indicated by OS, and you're going to see that a lot. And this is calculated from the first day that your myeloma treatment started. And these two graphs here are the sorts of things that you would see, and this is what is shown for Velcade, Revlimid, and Dex as a first treatment. And so what you can see here is that the average in this treatment, which started in 2007, so that it's improved now, you see it was a little bit less than 4 years was the average. And you can see the overall survival. With this study that started in 2007, over half the patients were still doing well at 7 years. And so this gives you some perspective of what to expect. And as I indicated on my first slide, in 2021, things are continuing to do better and better in terms of these numbers. With a combination of daratumumab, Revlimid, and Dex, for example, that average is over 4 years, maybe 4.5 years, and the anticipated average survival is going to be equally somewhat longer. Yeah, so those are the highlights to be aware of, that 80% and 55%, which are kind of a baseline these days. It's going to be better than that, actually. So this diagram here, I think maybe will help you to understand what we're expecting to happen. So you get that first treatment, which could be, for example, Velcade, Revlimid, and Dex. We are expecting a deep first response. So that green arrow will come all the way down beyond 50%, maybe down to 75% or even 90%. And if you're lucky, it might go down all the way to the bottom where there's MRD undetected. Now, let's say you have a very good a VGPR or maybe a CR. The green light, you'll see, the green line rather, you'll see it goes flat. And so that's your first remission, which you can see there, it goes out into the 4 to 5 year range. And after that, it may be that we find that first biochemical relapse where the protein level comes up and the doctor says, uh-oh, we should maybe change your treatment at this point and get you back into remission quickly. And then you can see these days, chances are we can rapidly achieve that. And then that green line goes flat again, moving out towards and maybe beyond 10 years. Now, you can also see on this slide is that if you happen to get to that MRD level, so if you have a fantastic response, that bottom line goes out a much longer distance, and it itself can be out beyond 5 years, out to 10 years, and then there's a later relapse from that MRD undetected level, and then that might be need to be dealt with, but at a later time frame. And so I think it's helpful to have this kind of a perspective. All right. So what are the options? And I'm not going to go into this in great detail because this is what we're going to be doing tomorrow. But in general, most of you have probably received a 3-drug combination. Typically, it would be Velcade, Revlimid, and Dex. If you're older or more frail, maybe the doctor said, let's just give you 2 drugs, which probably would be Revlimid and Dex, or it might have been VD, Velcade, and Dex, so a doublet versus a triplet. And most likely in that 90% range, you've had a good response to that and are probably doing well. For some patients, maybe the treatment has had to change to get that best response. And at this point, for many of you, there's probably been this next decision. should you have an autologous stem cell transplant? And this can definitely be considered to achieve a better response. This is an area which is a little bit controversial right now. If you happen to have achieved that MRD negative with just the frontline therapy, it may be that you do not need to go ahead immediately with that autologous stem cell transplant. But I would say for a majority of patients, if there's some myeloma left, and if you're younger and if you're in good health, I would really encourage you to talk to your doctor about doing autologous stem cell transplant. Because yes, it's a major procedure. However, we've been doing it for over 20 years now, and so we have a lot of experience, and usually we can get you through that without too much trouble. Now, along the way, especially if you had significant bone problems, you're probably taking either Zometa or maybe Iridia or maybe the newer medicine, denosumab, for the treatment of bone lesions, and this would be fairly common. So triple drugs, Velcade, Revlimid, Dex, yes, sir. Autologous stem cell transplant, maybe. And Zometa, Iridia, or denosumab, probably, yes, you're taking one of those. Other options to consider down at the bottom, there are quite a few options. Instead of Revlimid, Cytoxan is sometimes used. Instead of Velcade, sometimes Kyprolis is used. And then sometimes we use daratumumab with the Rev-Dex, that's called the Maya regimen. And sometimes these days we will even do what's called a quadruplet, where we'll use 4 drugs, where you would take the Dara in addition to the VRD. So different variations. Maintenance, typically we recommend maintenance right now. So once you've gone through that first therapy and possibly the transplant, we would recommend staying on a maintenance for a year or 2 or 3, or sometimes for longer. Typically that would be with Revlimid. If you have abnormal chromosomes like that 17 chromosome abnormality, we might suggest adding in Velcade or Ninlaro, which is a by mouth proteasome inhibitor similar to the Velcade. That could be a helpful thing. And we have a lot of articles and information about this kind of decision process, depending on the status of your myeloma and different things in your personal situation. And then finally, I just want to touch on that this diagnosis had a huge impact on the myeloma patient, but also on the whole family. And people who are helping you to care for yourself or your family members and the like, they need to have some attention too. And so we do want to be able to be in a position to help you, but also to give support for your caregivers. And we have a lot of activities that can help with that. Yeah. And so with that, I'll close my formal comments, and then I'm going to turn it over to Robin, who will lead you through myeloma.org, our website, and show you where some of these things that I've referenced can be easily found on the different web pages. So thank you for your attention, and I'll turn it over to Robin.
Okay, thank you so much, Dr. Dury. That was so helpful. And I think for everyone on the call today, if you'll be participating in tomorrow's amazing program, this primer helps you to really better understand things, especially all of these abbreviations that we hear. And every time we hear a program, we hear it a little differently, because whatever you're focused on, if you're newly diagnosed, first treatment, second treatment, your ears tend to hear what you need to know at that time. So we're really thankful you were able to join us today. And so my goal is to kind of give you homework to do. So after today's presentation and after tomorrow's presentation, you don't feel alone. You have somewhere to go to find these additional resources to give you the answers you need to know now. So as I scroll through here, this is myeloma.org. It is the IMF's website. And this is the front page. And when you come up to the IMF website, the first thing you'll see is this little bubble down in your bottom right. That is the IMF info line. So if you have a question, you want to ask about a resource, a treatment, a side effect, any questions you have about myeloma, you can call the IMF info line. This number will always pop up when you first go to the IMF website. For our purposes today, I'm going to click on the X and say goodbye to that bubble so we can see the page a little bit better. And I'm just going to scroll down to show you a few things and walk you through the website. So first here you'll see IMA. This again helps you to focus in. So if you're a patient or if you're a caregiver, this is where you're going to want to click to really be directed to those pages that will be most beneficial to you. Now this front page of the IMF website changes daily. So I usually tell people, go back here once in a while, maybe once a week, see what's new, even just to scroll through the front page. And you could see we always now have information about COVID-19 and vaccinations for myeloma patients. So of course, that's a very important area. I'm not going to go into each one of these. I just want to take a quick scroll down so you could see a little bit of what the content is here on the page to have an idea. I'm sure tomorrow you'll be hearing a little bit more, maybe a lot a bit more on CAR T therapy. Of course, that's a really big and important, exciting new immunotherapy. We also have another webinar coming up on May 6th about living well with myeloma and using your immune system and nutrition, and how nutrition can help your immune system. So that's really important. So you could scroll through at your leisure, but right now I want to go to back to the top of the page to show you a couple of things to focus in on. Dr. Dury talked a lot today about what is myeloma. So this little bar here at the top that I'm circling my cursor over, if you click on this, you get a drop-down box. All of you were invited to the program today because you are newly diagnosed with myeloma. So this is a section that you may want to come to learn a little bit more about. We did talk about types of myeloma. If you wanted to read a little more, you can click there. And then urgent problems at diagnosis. So you're past that early diagnosis, but sometimes people have urgent problems like kidney issues or bone lesions and issues with compression of the spine. So to learn more about that, this is a very good section to go to. Tests and staging, I think you're all a little bit past this, but this is a very helpful area. But now over on the right where it says treatment, what are those frontline treatments? This is really a good place for you to go to. And if you're at that point now where maybe you had your first remission and things went well for a little while, and then you relapse. So these are places for you again to go. I look at it as not waiting for the shoe to drop, but learning what I need to know. So when and if something happens, you won't need to do the research when your brain is all in that panic state of, oh no, you know, I've relapsed, now what? But if you kind of learn about what are those things I need to know for the future, it helps you to stay more focused. It helps you to have good conversations with your doctors about your future treatment plan. I'm a big planner, and I think that planning and thinking about what if, not in a bad way, but what if in an educated way can help you. And for me, that takes away my anxiety, and I hope that it would for you too. The next thing I will click on really quickly to show you is this third line down under treatment. It says FDA approved drugs for myeloma. When you're newly diagnosed, you have no idea, first of all, what is myeloma, never mind what are the treatments available for it. And on Dr. Dury's first slide, you saw that today people are living longer and we have more treatments available than ever. So what are those treatments? This is the page where you can come to and learn what are the proteasome inhibitors. So that's a category, a mechanism of action, a type of therapy to fight myeloma. And then it's all by types of therapies. These are the IMiDs, so they're all categorized together. I'm going to scroll down. I'm not going to go through each one of these, but I just want to show you at the bottom of this page, there's something that I love. I show support group members this chart. Download chart of approved myeloma drugs. If you click on this, a really nice chart pops up. You may not be able to see it well. It may be small on your screen as I'm showing you, but I just want to show you where it is and what's on it. So you have the drug type name, the generic name, so before it gets approved, and then what is it indicated for? Why and when would you use it? And what type of a drug is it? Is it intravenous? Is it sub-Q? Is it oral? And then what are the side effects here? And then additional remarks. So you can turn the page, and when you're on a computer screen looking at resources, always put your cursor over to the right-hand side where I'm circling around here. You can see there's a little arrow. If you click on the arrow, it turns the page, just like you would in a book. And I'm showing you this because now you see new drugs. And then I like here under the remarks that a lot of these pharmaceutical companies have support pages, whether it's financial aid programs, so you can be directed right to those page-specific programs. So this is a really handy-dandy chart. I would encourage you to remember where it is. I'm going to scroll back up to the top so you can see again how I got there. So it was under this block that says, what is myeloma? It was under treatment, and then FDA approved drugs. That's where we went. So now we're going to go over to this next block that says publications and videos. Dr. Dury gave you a lot of really good information today, and you can find that and additional information in the IMF publications. So they're all available to read online. I am going to click quickly on the patient handbook. I'm trying to watch the time. I see that we're close to out of time, so I will go quickly. The patient handbook. This is so important for you to read, and you may have already received this in a welcome packet, and if you did not yet receive it, we're sending out another shipment, so you should receive it by next week. But again, look how easy it is to read a book online. Just click this little arrow and you could read the pages just as easy as that. So in the matter of time, I'm not going to go through all of these, but there's lots of booklets here that I would highly encourage you to read. The Understanding series, those booklets, there's one on every single myeloma drug that's approved, and it will go into detail on that drug, as well as things like side effect management. So check these out. And also, if you have not yet signed up to receive an email once a week to give you, here's this week's updates, what you should know about myeloma. That's called the Myeloma Minute. If you click there, you can sign up and get that, and it will come into your emails once a week on Thursdays, and you'll be totally up to date. Myeloma Today is a printed publication. Again, these are free. Of course, everything the IMF does is free to you. Broadcasts. This is so important. I will click on this very quickly to show you what's in here. Many people, and I've seen in the chat box, people are wondering if this is recorded and will it be available for a replay. So this is where you come for the replays. All of the IMF programs, the content is located in here. We're now looking at all content, but many times people just want to go to Ask Dr. Dury. And I'm going to click on that to show you. These are wonderful 5-minute videos or less on hot topics, and patients will call the info line or write an email in to say a question they have. So there are many, many questions in here on myeloma, on COVID-19, on vaccinations, and you could scroll through here to see all of that good content. I'm going to click now very quickly on resources and support. Because many of you are new and because I find such value in a support group, I will highly, highly encourage you to find a local group near you. And how would you do that? Right here on this button, find a support group. And today, all of the support groups are meeting virtually because we're still trying to safely meet. We've got over 100 groups safely meeting virtually. But if you wanted to find your own local group, this is a handy dandy map. You can type in, let's just type in Florida, and you will see all of the support groups in Florida. They're listed here. They're also listed down here below where it will give you more information on the time they meet, and then the IMF creates local support group websites. So if I clicked on the Boca Raton website, now you go right to your local resource. And so you'll find out more information about when this group meets. So please, I highly encourage you. Support groups are not about, woe is me. It's really about learning from each other, sharing your experiences. The groups have excellent speakers and resources. So again, I highly, highly encourage you to find your local support group. And I want to make sure that we're saving enough time for all of you to ask any questions. So I think I will end our walk through the website at this point, but please take your time and look through this. And if you have any questions, feel free to reach out to me or the info line.